The broadcast is now starting. All attendees are in listen-only mode.
Good morning. Thank you for joining us for CAPHC's Patient Safety Collaborative webinar. My name is Lisa Stromquist, and I'm the Coordinator for Quality and Patient Safety at CAPHC. And before we get started today, I want to provide you with a bit of the technical details. So all of the lines have come in muted so that there's no background noise to distract our presenter. And you should notice a question box in the right-hand side of your screen in the control panel. So as the presentation unfolds, please feel free to write your questions or comments in as they occur to you. We will have a more formal question and answer session following the presentation. And if at that time you would like to maybe be unmuted and speak directly to Dr. Friedman, that would we'll do our best to make that happen. So like all of our presentations, this one is being recorded, and the recording will be posted on the CAPHC Knowledge Exchange Network on this page right here. And it usually takes a day or two to get all of that information up, and you will receive an automated message from our system with the direct link to the page in the recording. But you can also use the search function here on the Knowledge Exchange Network to find this presentation or any of our other presentations from our archives. And the Knowledge Exchange Network also provides an opportunity for you to leave comments if you're a registered user and sort of keep this discussion going. And you can post any other relevant information that you might have. So today's presentation is Say Yes to the Less. It focuses on the Choosing Wisely Canada campaign from a pediatric perspective. So it is my pleasure to introduce Dr. Jeremy Friedman. He's a pediatric hospitalist for 20 years. And Dr. Friedman is Associate Pediatrician-in-Chief at Sick Kids Hospital in Toronto and former Division Head of Pediatric Medicine. And he's Professor of Pediatrics and Associate Department Chair at the University of Toronto. So he's authored more than 80 peer-reviewed publications, many book chapters, and 8 books. And I'd invite you to read a little bit more about Dr. Friedman on the Knowledge Exchange Network, and there's a link to his larger biography as well. So right now I'm just going to change the reins over to Dr. Friedman.
Great. Thanks very much for that introduction, Lisa. I'm hoping everybody can see the slides. So thanks to CAPHC for inviting me today, and thanks to everybody listening for taking time out of your busy day to hear what I have to say. And I feel actually really excited about this because this is an area that I'm really feeling quite passionate about. And I think certainly as a general pediatrician, as a hospitalist, as a parent, I think this is something that that is really, really important. So, you know, whether you are a fitness fanatic or whether you prefer to eat a hot dog on the couch, what I'm hoping is that in the next 40 minutes or so, I can at least get you thinking that more is not always better. So what are my objectives today? I'm going to try and explain to you why I think we need to be thinking more about choosing wisely. I'm going to highlight a little bit about the pediatric involvement that I've seen so far, particularly in Canada. And then in the second part of the talk, I want to talk a little bit about an initiative that we've started at our children's hospital here in Toronto. It's very much in its infancy, but I think it might stimulate some thoughts and some ideas for folks out there. And I'm hoping we'll have about 20 minutes at the end for people to sort of give us a little bit of their experiences, suggestions, thoughts, and certainly I'm happy to answer any questions that people might have. I think that the topic of choosing wisely has actually become quite interesting, and a lot of people are starting to think about it. I think just last week, one of my favorite sources of medical information, Andre Picard at the Globe and Mail, wrote a really nice article, and at the bottom I've put the reference to that article. And I like particularly one thing he said, which was kind of, I thought, quite cute. He said, "Don't just do something, stand there." I thought that was kind of neat. Anyway, it is interesting that we talk a lot about underuse, for example, in the context of vaccination. We talk a lot about misuse in the context, for example, of medical errors. But really, until recently, I think there's been very little discussion about overuse. So why is this important? There are a lot of very good references that would suggest that probably in the region of 20 to 30% of all the tests and investigations that we do in North America are probably unnecessary. I put in one reference there, Donald Berwick from JAMA, but there's certainly a whole bunch of references that I think support that this is probably not, that this is quite a reliable figure. If anybody wants to know in terms of dollar value, about 5 years ago it was estimated that just in the US alone, probably $200 billion were being spent on unnecessary tests and therapies, which add no value. And even more concerning, I think, for us as healthcare providers is that some of these certainly can cause harm. An example would be, certainly if you do a whole lot of tests, you're going to get some false positives, which I think we all know tend to cause quite a bit of stress and will often lead to more testing, and the cycle continues. For those who like to read well-written articles, Atul Gawande, I put that right at the bottom, wrote a lovely article in the New Yorker last year called Overkill. And he's a surgeon in Boston, writes a lot about quality issues in the healthcare system. And he talks about his experience. His specialty is thyroid cancer, and about how he is being forced to remove tumors that are being picked up, which probably would not harm anybody at all, but once people know about them, they're absolutely adamant that they want to get rid of them, and he calls them incidentalomas, and about the harm that sometimes unnecessary testing does. Very well written article. So why and how did we get to this? So I think one of the typical answers is that the patient is asking for the test or the therapy and the patient wants it. Another one is that, there's been so much advance in healthcare in the last few decades, actually very, very hard to keep up with stuff, but new tests and new therapies always sound like they're going to be extremely helpful for patients. I think there's a bit of a misconception that it's better to do something than nothing. Certainly, I think all the time we see families sort of misinterpret over-investigation for thoroughness, and on the other side, often feel that healthcare providers that aren't providing testing or therapy are not sufficiently thorough or not really, just don't care enough. Sometimes we feel that the patient's been referred to us because the doctor actually wants testing or therapy. I think a very real issue for most of us is we never want to miss anything. We certainly don't want to get sued. There are financial issues. Marketing is very, very powerful. It's interesting that I think certainly as physicians, we are all adamant that we're not influenced at all by pharmaceutical or technology companies, but I doubt they'd be paying billions of dollars in marketing if they didn't have some effect. And there's just old habits and the way that we've always done things. So a lot of reasons why I think we are tending to do more than we necessarily have to. I put a little reference in there, New England Journal of Medicine, a couple of months ago, talking about the science of choosing wisely. And it points out the concept of the therapeutic illusion, which basically means that we believe that our actions are actually more effective than they really are. So an example of that would be, child comes in with a sore throat, we put them on antibiotics, they get better. We choose to believe that they got better because of the treatment that we gave them, when in fact, of course, they would have got better even if we did not give them the antibiotics. So how do we reverse this trend? I think one of the really exciting initiatives that have come out recently is the Choosing Wisely campaign. It's a relatively new initiative, started in the United States just 3 or 4 years ago, and it is a campaign to help physicians and patients engage in conversations about overuse of tests and procedures and support physicians to help patients make smart and effective care choices. And it didn't take long to come up to Canada. It's been in Canada for a couple of years under the leadership of Wendy Levinson, who was head of the Internal Medicine Department at the University of Toronto and the UHN, and in partnership with the Canadian Medical Association has spearheaded the Choosing Wisely Canada campaign. Very much a clinician-led, from the bottom up campaign, trying to look mainly at common conditions, both in primary care and specialties. And one of the big sort of instruments is the top 5 list, and I'll talk a little bit about that in a moment. So I've put the website for Choosing Wisely Canada at the bottom of this slide, and I just want to put a shout out for the team there. I think it's a great website. The folks that I've interacted with at Choosing Wisely Canada are incredibly engaged, extremely helpful, and I borrowed the next few slides actually from their slide deck, but I would certainly encourage people to look at this site. It's full of very helpful information, and if you get in touch with the folks there, they're very, very helpful. So in terms of Choosing Wisely Canada objectives, I'm not going to read through them, but basically encouraging physicians to engage in conversation with patients, empowering patients, cultivating a culture of responsible stewardship, getting people talking, and engaging stakeholders across the country in terms of policy change. And the campaign is multi-pronged. Certainly a big part of it is through physicians and particularly subspecialty societies across the whole country, but increasingly patients are being approached particularly through the development of materials that are appropriate for patients, and then there's a really active media campaign to get the ear of stakeholders who can help to change policies. I talked a little bit about the top 5 lists. So one of the mechanisms is to ask subspecialty societies to come up with 5 recommendations to guide healthcare providers in terms of trying to curb overuse of tests and therapies. And to a large extent, the societies can determine how they would do this. Most societies, I think, have gone out to their membership and asked for suggestions, and then through some kind of voting process or Delphi process, they've come up with 5 items which basically must have a strong evidence-based support, and the sort of mechanism by how they came to those items needs to be sort of transparent. This is a nice slide just to show you what tremendous sort of engagement the Choosing Wisely Canada group has got in a very short period of time. So there are more than 45 subspecialty societies or associations across Canada that have sort of signed on and created their lists, which translates to more than 170 individual recommendations right across Canada. Increasingly, patient materials and pamphlets are being produced. As I mentioned, media is a big part of it, so both the traditional media as well as social media. And then, in fact, Canada's leading sort of international collaboration of about 17 different countries, all engaged in similar work simultaneously. So the website also has a growing library of what specific organizations are actually doing. And to some extent, the creation of the top 5 list might be one of the easier parts. As you can imagine, implementation of the recommendations, I think, is where things get really tricky. And I like this slide. It talks a little bit about engagement in education, looking at individuals, leadership, and physicians and patients. It talks about quality improvement and the importance of measurement and audit and feedback as a mechanism. And then it talks about policy changes, using the organization as a way of ensuring change. So a nice resource if you're looking at some helpful tips towards implementation. And then I just wanted to show you one slide of what I would consider a really encouraging sign that at North York General Hospital, which is a community general hospital, just 20 minutes up the road from where I am at Sick Kids, they embraced a whole bunch of the top 5 lists in the adult world and embedded them in their emergency department. And what they're showing here is a 40% decline in the number of tests that were done in their emergency department over a 10-week period after implementation of this initiative. And it's just one of a number of growing examples of potential impact that something like this can have. And then I'm just showing you this slide for a number of reasons. First of all, as providers in the pediatric world, I think we all know that if you want to impact behavior, you have to intervene fairly early in the development of the individual. And I really like this particular list because it's basically the medical students and trainees in Canada got together and they created, in fact, not a top 5 list, but a top 6 list. They were so engaged and excited about it that they couldn't actually restrain themselves to 5. They actually landed up with 6. So I think it's really a nice example of the younger generation being conscious of the issue around sometimes less being more. And I don't know how well you folks can see it in front of you, but I'll just give you a little flavor of what they're talking about. Number 1, don't suggest ordering the most invasive test or treatment before considering other less invasive tests. So if you can do an ultrasound, definitely don't do a CT scan. Number 2, don't suggest a test, treatment, or procedure that won't change the patient's clinical course. Again, if you don't think that the test that you're going to order, the results will impact in any way on what you're going to do for the patient, then clearly you should be questioning whether you should be doing that test. Don't miss the opportunity to talk to the patient. We always assume that the patients are driving the overuse, but sometimes if we take the time to explain the pros and cons, risks and benefits, it actually flips around and in fact the patient is not that keen to have an unnecessary test after all. Don't hesitate to ask for clarifications if you believe the tests treatments are unnecessary. I work in a big teaching hospital and there's certainly a hierarchical system, and I think it's fantastic if we get our trainees to keep us honest and keep us on our toes and make sure that we're not just going with old habits and we're sticking with the evidence. Number 5, don't suggest ordering tests or performing procedures for the sole purpose of gaining personal clinical experience. I think it speaks for itself. And number 6, don't suggest ordering tests or treatment preemptively for the sole purpose of anticipating what your supervisor would want. I think my trainees are probably a little on the opposite end of the spectrum. They're pretty nervous when they order something if they the next morning can't really justify it. But I think there's a good dynamic tension there. So I think, and this is a nice example of what the Choosing Wisely Canada top 5 lists would look like. They have a very standard template. The wording has to be pretty similar. And it helps sort of keep everything standardized. So I now want to move on to just giving you a brief overview of what's happened in pediatrics, and almost all of the Choosing Wisely recommendations and items are actually in the adult domain. There's been very little activity in pediatrics, and what activity there has been, quite honestly, has mainly been in the US. I'm not aware of much pediatric Choosing Wisely activity in Canada to this point. So in terms of pediatric lists, I could find 4: the American Academy of Pediatrics, the Society for Hospital Medicine Pediatric section, and then the Rheumatology US body has a pediatric subgroup, and then also newborn medicine. So I just wanted to give you a little flavor for what is out there in the US. So the American Academy of Pediatrics has actually 10 things. These are the first 5. Probably most of them won't surprise you. The top one is antibiotics shouldn't be used for apparent viral illnesses. we know that the CDC estimates that more than 50% of antibiotics that are prescribed in the outpatient setting are probably unnecessary. Cough and cold medications shouldn't be prescribed for respiratory illnesses in children under 4. And then the next 3 are around neuroimaging, particularly CT scans, shouldn't routinely be done for minor head injuries, simple febrile seizures, or routine evaluation of abdominal pain. The next 5, and I'll let you read them yourselves, but again, most of these are geared towards, I would say, community-based practice, office-based community primary care pediatricians, not very much related to hospital-based practice. And this is a little bit of closer to my particular area of interest, the Society for Hospital Medicine Pediatric Group. Here's the reference, came up with their 5 top items. And for those of us who work in hospital pediatric medicine, these will probably resonate a little bit, mainly around respiratory illness. So don't use chest x-rays in children with asthma bronchiolitis. Don't use bronchodilators in children with bronchiolitis. Don't use systemic corticosteroids in young children with lower respiratory tract illness. Don't treat gastroesophageal reflux routinely in infants. And don't use continuous pulse ox in children with acute respiratory illness unless they're on supplemental oxygen. So probably not anything terribly surprising. I think a lot of these things we're quite aware of. I'm not going to go through these, but I just wanted to put it there in case people wanted the references. These are the top 5 pediatric rheumatology, and then here's a reference for the newborn medicine top 5 list as well, and this will be a resource if you want it, but I'm not going to go through that. So that's very nice, but I think most of what I've told you, you probably knew already, and most people out there probably would know that as well. But how do we actually overcome the inertia? How do we break the old habits? How do we get by this perceived patient-parent dissatisfaction if we don't do the tests or give the therapy? How do we get past the fear of missing something or lawsuits, etc., etc.? So, I mean, I don't have a perfect answer for you, but I do have some thoughts that can be learned from some of the successful initiatives that have been undertaken so far at the various hospitals in the last couple of years that the Choosing Wisely movement has been active in North America. So, and I'll just highlight these very quickly before going on to tell you a little bit about what we've done at Sick Kids. So some of the principles are, it's imperative to have the support and very clear, visible support of the local hospital opinion leaders. Critical to have champions on the ground who are passionate about the particular project or items. None of these things are easily achieved, and for busy clinicians with a full-time clinical caseload, probably almost impossible to really get these initiatives going. So the importance of project support has to be recognized. Measurement is critical. You probably all know what we don't measure, we can't manage. So measuring the baseline and incidence is critical. Starting with the sort of low-hanging fruit, something fairly simple where one could perhaps get some quick wins, some positive outcomes would be really helpful. QI methods, PDSA cycles, lean methodology, there's a whole lot out there. And then just to highlight that, you know, when you look at these items and recommendations, it's not black and white. It's not right or wrong. Almost all the things that people are being told not to do in routine circumstances, they obviously will need to do those things in justifiable circumstances. I think what one's trying to get across is just to not get in the habit of doing everything to everybody, but just being a lot more thoughtful and critical about when to use x-rays or when to use reflux medications or whatever the case may be. And then the concept of trying to improve quality of care and education as opposed to penalizing or censuring the faculty. And feedback and audit is extremely helpful. There's a lot to be learned from the social psychology and behavioral economics literature. I read a really nice article in the New York Times describing a JAMA article where they were trying to decrease the number of inappropriate antibiotic prescriptions by community primary care providers in the adult world in the U.S. And they used posters, they used education, they used a whole lot of things, and they couldn't impact it at all. And then what they did was essentially sent each individual practitioner a report card with what their results were, what their inappropriate antibiotic prescribing rate was felt to be, and how it compared with 800 of their peers. And that actually resulted in an 80% drop in inappropriate antibiotic prescription. So just an example of the power of feedback and audit. So the last part of my talk, maybe the last 15 minutes or so, I wanted to talk a little bit about the project that I've been involved in at Sick Kids. And maybe I'll start out by explaining to you, I mean, one of the things that I guess was the final straw that made me decide I wanted to do something about this was last summer I was at a meeting, and I forget the exact context, but people were talking about nasopharyngeal or NP swabs looking for common respiratory viruses. And essentially what was being presented was that in our emergency department at Sick Kids, which quite frankly I think is a very good emergency department, some outstanding people, very high interest and activity and quality initiatives and things like that. They were looking at their results for the previous year. They performed about 2,500 nasopharyngeal swabs, which for those of you who aren't familiar with it, basically means if a child comes in with respiratory symptoms, somebody takes a Q-tip and sticks it up the one nostril, and you have to be a little bit rough to get a few cells. Usually the baby cries, the family cries. Nurses don't particularly like doing it. Anyway, in our setting, you would send that up to the lab, and in 24 hours you'd get a result telling you about the 6 most common respiratory viruses, so things like RSV, influenza, parainfluenza, adenovirus. And the important part of the story is that of the 2,500 NP swabs that were done last year in our Sick Kids Emerge, about 500 of the kids were admitted, and maybe the results may or may not have been useful. That depends on the opinion of who you speak to. But 2,000 out of the 2,500 kids went home from the emergency room. And what we realized was that even though these swabs were going up to the lab and being analyzed and reported, there was no sort of closing the loop. So the actual result didn't go to anybody. So nobody in the emergency department actually checked to see if the swab was positive or negative. And the result didn't actually go to the primary care provider or to the family. So essentially, nobody was worried or concerned enough about that the result would change anything or would be helpful enough to follow it up, which I think we would all agree suggests that you probably should not have been doing that test in the first place. So for me, that was kind of, and I just give you that as a simple example, but I think if that happens in an excellent emergency department, in a pretty good children's hospital, I suspect there's probably a lot of these kind of things that we would find all over the place if we look carefully enough. So that kind of motivated me to say, hang on a second, let's just see if we can do something to look at this a little bit more closely. So, and I wanted to do something that we could get going really quickly. I didn't want a 5-year project type of thing. I wanted things to move along quickly. So in the summertime, I approached some of the stakeholders, diagnostic imaging, pediatric lab medicine, pharmacy. We have an antibiotic stewardship committee, and then some of my colleagues in general pediatrics and in the emergency department, and asked them to suggest some potential items for a top 5 list for sick kids, because quite honestly, the AAP list, you know, because it's based sort of on community office practice, really wasn't at all appropriate for our patient population. And then in addition, I went and I looked through all the Choosing Wisely specialty lists, and I took any items that I thought might be appropriate for pediatric hospital patients. And I came up with 22 items, which I then took to one of our clinical departmental operations committee, and with an expert group looked at the evidence and the appropriateness, and based on that came up with the 12 top items that we thought might be helpful. The next step was to take these 12 items and, using SurveyMonkey, sent the items out to our full-time faculty and residents and gave them a little bit of an instruction as to what we were hoping to do, and asked them to score on a Likert 1 to 5 scale, with 5 being the most important, which of the items they felt were most appropriate for our setting at Sick Kids in Toronto, and we gave them a week to respond. And then the next step of the process was to look at the higher scoring items and factor in things like implementation, measurement, value, and whether there were any hospital quality initiatives in process at the moment that we could align with before we came up with our final 5 items. And then we also wanted to be able to pick a physician champion for each item. I'm not going to go through this in detail at all, but this the point of the slide is, so these are the 12 items. The wording isn't quite as we sent them out. It was a little bit more clear, but just in the interest of getting it on one slide. And the point that I want to make is, first of all, the faculty response. We've got 120 responses out of 170 full-time faculty. So about 70% responded within a week, which for a survey is almost unheard of, to be honest. So it sort of speaks to, I think, the fact that the choosing wisely issue resonates with people for sure. And the residents as well, we had an outstanding response from them with 49 people responding. So people were really interested. And this is our list of 5, and I'll go through them one by one and give you a little taste of what we've done with it so far. So we started the project in the summertime. We reached our 5 items by January, and with the 5 items, when we sort of circulated them, we also sent at least 2 or 3 good, up-to-date references, usually recent guidelines, which backed up the evidence behind the suggestions that we were making. So not surprisingly, after I told you that story, one of the ones that did come up on our 5 items to deal with was, don't routinely order NP testing for typical respiratory illnesses unless the results are likely to impact management. And I'm just going to give you a little bit of a, not a comprehensive description, but a little bit of a taste of what the individual groups have done, bearing in mind that they really just got going in January, February, so we're only about 2 or 3 months into the project and mainly have baseline data and not a lot of results so far. So we appointed a champion, and in the case of the NP swabs, it was an eMERGE physician who was quite involved with quality work, and had just finished an excellent project on rapid strep testing in the eMERGE, so pretty closely aligned with that. We reviewed all the baseline data, and what their group decided, in conjunction with infection control people and ID specialists and ED faculty, was to completely revamp the way that NP swabs were done. So they decided to change the whole protocol to a point-of-care rapid influenza test, where if you did the test, you'd get the result back in less than an hour. So it would actually potentially be useful for the eMERGE people if they felt it would be. And then do away with our old NP test and go to a more sensitive and specific one that looked for 16 respiratory viruses, but would still take 24 hours to come back. And they drew up algorithms with specific indications that you would have to indicate if you were ordering either of these tests. Our eMERGE is still paper-based in terms of orders, so it was embedded in the paper orders. The rest of the hospital is on computer order electronically, so the changes were made there as well. And the education program was disseminated. This is just a very quick look at what the baseline data was. As I told you, last year, 2,600 NP swabs were done in the emergency room, and at least 2,000 of those were not really followed up in terms of the results. This is just a slide of what the paper order looks like for ordering an NP swab now in the emergency department. Put the patient sticker on there. In clear red letters it says, routine testing for respiratory viruses is generally not indicated for otherwise healthy patients. On your left-hand side, it talks a little bit about the rapid influenza point of care test. And if you are going to order it, you have to indicate what the actual indication is, and it gives you a little asterisk with what kind of patients it might be appropriate to use Tamiflu, and therefore to know whether the patient has influenza or not. And then on the right, it talks about the respiratory multiplex PCR test, and again gives you some very clear criteria, and you have to tick off one if you want the swab to actually be done. And on the next page, there's a nice information for evidence-based decision-making, which talks a little bit about influenza and Tamiflu and a little bit about the properties of the testing. This slide is just to represent the computer order entry changes, where again it tells you routine testing is not indicated for otherwise healthy patients. And this actually just got the slide literally yesterday, and I don't want people to read too much into it. What it's showing is in blue the NP respiratory testing for 2014, in red 2015, and in green 2016. It actually looks incredibly impressive. I think it's not as simple as that, because to be honest, we have to factor in the fact that we now have introduced this new influenza point of care test, and people, particularly in the last month or two with a pretty awful flu season, have used that test quite a bit, so we have to factor that in as we look at total sort of utilization. But I think regardless, when we've been able to analyze the whole season, I think what we are going to for sure find is that people have been doing the test in a much more appropriate fashion and have been able to interpret and use the results in a way that we would assume would actually add value to the patient's care, as opposed to just doing the test because it's something that always seemed to be done and seemed like a good idea at the time. Just a few more slides. So the second item on our list was, don't routinely perform a VCUG in infants after a first febrile UTI. And this is very clearly a recommendation in all the recent guidelines from the US, Canada, and the UK. And interestingly enough, when we put the group together and they actually looked at the baseline data, they looked at about 200 children admitted with typical UTIs to our general peds floor, they actually found that over 80% did not get a VCUG ordered, and of the other 20%, 18% of the VCUGs were absolutely appropriate based on an abnormal ultrasound or some other indication, and there were only actually 1 or 2 cases in the whole 200 that got an inappropriate VCUG. So in fact, we feel that this item is being done very well at the hospital, and what we're going to look at is community practitioners ordering a VCUG to see whether the statistics on that look anything like this, and if they don't, then our efforts will be aimed at community practitioners and not our own faculty at the hospital. The third item is, don't use continuous pulse ox routinely in children hospitalized with acute respiratory illness unless they're on supplemental oxygen. And there's increasing evidence to suggest that this doesn't really add value to the care, but it does increase the length of stay and the interventions. In this case, we picked a champion who's a general pediatric hospitalist who actually has a research interest in this particular sort of question, and has done quite a bit of research work in looking at monitoring of children with bronchiolitis. We've just completed the baseline data collection. In this case, it was extremely important to put together a multi-D team because, as you can imagine, pulse ox is a nursing task, and the respiratory therapists are involved as well, so they were all part of a multi-D team together with the trainees. And I'll just show you the baseline data, which suggests that in children who were not on supplemental oxygen with bronchiolitis or asthma or pneumonia, about 60 to 70% of them are getting continuous O2 sat monitoring. So clearly there's a lot of room for improvement. So we're just at the starting phase for this particular item, but we're hoping with the various electronic order changes and education and feedback and audit that we will get way down from 70%, which is where we're at the moment. The fourth item was don't automatically give IVIG as first-line treatment for children with newly diagnosed typical ITP. And this is a slide showing what happens at sick kids. So this is a very specific, this is an example of where your local culture, your local hospital institutional practices are really relevant to what you choose to focus on. Because I suspect there are many children's hospitals across Canada who use very little IVIG for ITP, but for some reason at sick kids, probably just because of some individuals years ago that had a particular preference for it. You can see on the left-hand side in the blue box, before 2010, 90% of our typical ITP patients were treated with IVIG, which is quite an expensive, invasive medication with some potential side effects. The champion that we picked is a general pediatric hospitalist who has been also working on this from a quality point of view in the last couple of years, and you can see that her work had already had some significant impact in that she had been able to bring it down to about 50% just with her QI improvements, and this is an example of sort of aligning one of our items with ongoing work, and we're hoping that with increased attention to this that we'll be able to bring it well below the 50% where it's currently at. And then our final item was don't use routine x-rays in children who present with acute ankle injuries and meet criteria for low-risk exam. Our champion here is an emerged physician who's particularly interested in ankle injuries and musculoskeletal research interest. She capitalized on the fact that a couple of her trainees were required to do a quality improvement project, so this particular item has become their quality improvement project, and they're in the process of modifying the x-ray requisition, and they've put up some posters in the emergency department, which includes the decision tree with the ankle rule, and there's a whole educational campaign that will start. And I'll just show you the baseline data, which again shows that there's a tremendous room for improvement in that at baseline, somewhere between 95 and 100% of patients with ankle injuries are getting x-rays in our emergency department, and there is good research to show that you could safely reduce this by up to 60% without decreasing any value or quality of care to the patient. So this is our baseline, and we're hoping to make some significant impact on those numbers. So I apologize if there was a real whirlwind sort of tour through choosing wisely, but I really wanted to leave some time for input from people who might have had some very different experiences or some more advanced initiatives, and leave some time for questions and answers. So I'll just finish off by a couple of take-home points, reminding you that I believe this to be true, that in North America, at least 20 to 30% of the tests and therapies that we order do not add value. I think there's 100 different reasons why we can explain this, but I think we kind of have to get over that, and we need to own this, and we need to do something about it. I think Choosing Wisely Canada is a tremendous initiative and a great opportunity. I think the team that I've sort of been in contact with in terms of helping me to do our project at Sick Kids been incredibly engaged and helpful, and this is a really good opportunity for everybody. If you're going to go with the top 5 lists, you can either adapt pre-existing lists for your own needs if you're in a general hospital or in a community-based practice where there's actually very good items that you could work on, or if you're in an area that you don't feel is sort of appropriately serviced by any of those lists, you can do what we did, which is sort of create our own list that we wanted to focus on. Measurement is absolutely critical. Implementation is the challenging part, and I will be the first to admit that we are at a very infant stage of our own initiative here, and you know, the next 6 months will be very interesting to see how successful we are in terms of results. And there's a lot of emerging experience, even though it's only been going for a couple of years, that I think can be leveraged, and we can all learn from each other. And I know that Prince unfortunately passed away yesterday, but my quote is actually from Jerry Garcia from the Grateful Dead, who said, "Somebody has to do something, and it's just incredibly pathetic that it has to be us." I think he was talking about saving the rainforest, but I kind of, I think it kind of sums up a little bit of what where we're at the moment. So I'm going to stop there, and hopefully there's some time for some good discussion and questions and answers.
Well, thank you so much, Dr. Friedman. That was great. I'm just going to remind everybody to type their questions or their comments into the question pane, or if you have a working microphone and you want to speak with us, there's a little icon. You can put up your hand, or you can just say, "Please unmute me" in the question pane. I don't have nobody's written anything just yet, so hopefully people are thinking of of what's going on in their own organizations, and maybe if they can share some of their thoughts about what's happening. I was just wondering, though, about sort of what's the parents' response. I know, I've had children. Thankfully, I've never had to bring them to an emergency department, but I could say that I would probably be a parent that would say to you, "Why aren't you giving him an X-ray for his ankle injury?" Like, are you getting? Do you have to deal with that?
So I mean, that's an excellent question, and it's interesting because in people who've studied parents' attitudes, it doesn't seem to be as obvious as many of us would have imagined. And certainly when you study it, parents actually often deny that they are the ones that are asking for the antibiotics or asking for the x-rays or asking for whatever it is. So certainly the evidence doesn't back that up that much. But you're right, anecdotally, I mean, I think there's certainly, we can all think of families that we see that do expect us to do certain things. I don't think there's a simple answer, but I think if one is willing to spend the time and explain, sort of the pros and cons, and, explain a little bit about what evidence is, and in fact, I think you'd be surprised at how often parents actually feel absolutely fine about antibiotics.
Mm-hmm. Great. Okay, I'm just going to, it looks like Tammy might, Tammy, I've just unmuted you. Did you have a question or a comment to make?
Yeah, I have a couple, but, oh, sorry, mine seems to be echoing. Can you guys hear that?
I'm hearing you fine.
Okay, I'll just go ahead. So thanks so much, Jeremy. This was an excellent talk and such an important discussion. My question is, I was just going through the web, just kind of snuck over to the website and saw, all the lists that have been created for the different areas, and I wondered if there was any movement or discussion around collaborating with either a hospitalist pediatric list or with other, maybe general pediatric or maybe subspecialty pediatric areas, so that we can do a bit more, I guess, consistency and sharing, because we could essentially apply a lot of what your institution has developed, and I think there's a lot of similarity across different locations.
Yeah, I think that's an excellent question, and I think that's kind of what was going through my mind when I sort of got involved with this. I think, and I can't speak for, I don't really have, obviously I'm not part of the Choosing Wisely Canada sort of central group, but I think that their sort of program really involves, you have to have a national society or a national association, so it has to represent the whole country. So in pediatrics, that basically is the Canadian Pediatric Society. And my understanding is the Canadian Pediatric Society are actually presently working on their Choosing Wisely list, and actually have been working on it for quite a while. My worry a little bit is that I don't think that the items are going to be a little bit more similar to the AAP, so probably a little bit more geared towards community practice and probably not as pertinent certainly to the bigger pediatric teaching hospitals and maybe not even community hospitals that much. So I think that it's, you know, the hospitalist group at the CPS actually would probably be would be the ones that would be tasked with the responsibility, because it has to be a national kind of group getting together. It can't just be one particular institution.
Great, thank you.
Okay, I have a couple more questions here. From Jennifer, do you feel that the process of creating a de novo list by hospital was valuable in getting upfront organizational buy-in? For example, as a pediatric hospital in Nova Scotia, should we adopt your top 5 list?
That's a good question, and I think it depends on how appropriate it is. So, like if I think about the example of ITP and IVIG, so if you're at a hospital, for example, where very few people use IVIG for ITP, then it really doesn't make sense to have that on your list. So I think, to me, I'm not sure that just using somebody else's list, unless it's a very, very broad practice like you know, the AAP list, and it's a sort of a community-based organization where I think nobody would quibble with any of those. I think, you know, one doesn't have to create the items de novo, but I think what one might want to do is look through the inventory of all the different lists that already exist and say, wow, that one actually works well for my hospital in Nova Scotia. Those don't, that one does, that one doesn't. And I think, yes, in order to get the buy-in of the hospital, which is, I think, is essential for success, you probably have to have some alignment with hospital strategic priorities and whatever quality activities going on. And that's going to be extremely difficult to just import a list from somewhere else. So, but I think there is the ability to look at some of the lists that I've shown you today, and even the adult list, that some of them are applicable for kids, and pick 5 things that would be really, really strategically valuable for your particular hospital.
Great. So I have another question. So many of the items on the list make sense, but I was surprised to see the continuous pulse oximetry. This is a standard of care in our institution for children with respiratory illnesses, except perhaps in the day or so before discharge once they are over the acute phase. What is the evidence that this is overused or unnecessary?
So it's a good question. I think the evidence is evolving, and I think it's, again, a nice example of where it's not black and white. And certainly using continuous pulse oximetry when the patient is still unstable, or when the patient is still requiring supplemental oxygen, nobody's suggesting that one shouldn't use continuous monitoring at that time. I think what the evidence is beginning to show is that once you're well enough to come out of supplemental oxygen, at that point usually the illness is fairly stable and is on the recovery phase. And what has been shown, in fact what's been shown even in kids that you send home from the emergency department with bronchiolitis, is that they actually have desaturations at home as well, which don't seem to cause any problem for them. And I think if you're in hospital and continuous monitoring, you're going to pick up every single one of those desaturations. The patient's going to be put back into oxygen, and it basically prolongs the hospital stay and all the risks that come with spending more time in a hospital. So I would say the evidence base there is still growing, and I don't want to say it's as firm as some of the other areas, but certainly in a lot of the most recent guidelines for things like bronchiolitis, in fact, the CPS guideline, I can say for sure, it does recommend that once the child no longer needs continuous oxygen, that you should be converting to spot O2 sat checks.
Great. So I have a question from Tanya. When caring for newborns in community hospitals, hypoglycemia is a common concern. However, the POC monitors are inaccurate at low blood glucose levels. Is there a way that choosing wisely could play a role in these guidelines? How could we lobby as a group the manufacturer of the POC glucometers for newborns to improve the accuracy at lower blood glucose levels?
It's not an area that I know a lot about because I don't really work in the nursery much at all, but I could certainly understand how dangerous hypoglycemia is and how important an accurate point-of-care test would be. So, I mean, certainly sounds like a really important issue. Choosing wisely is more about unnecessary, not indicated tests than specifically sort of, I guess, what is the best test. It's not, they're basically both related to quality of care for sure, but I'm not sure that one would necessarily be able to leverage the choosing wisely sort of lists, but I think it's a really important area and certainly would encourage you to keep looking at it. And I guess it's, to me, and I don't know much about the content, but it does seem to me an area where if one networks, with others across the country to see if anybody does have a point-of-care test that seems to work better. It's a little bit like what we've done with NP swabs. It turned out that the swab that we've been using for 10 or 20 years really was not a particularly good one, and when we sort of put some attention to it, we actually realized that they were much better, over the last 10 or 20 years, much better testing and more reliable and sensitive specific tests had come out, and maybe that would be the case with point-of-care glucose testing if one sort of casts the net really wide.
Great. So just a reminder to everybody, yes, the session is being recorded and it will be posted on our Knowledge Exchange network. And I will double check with Dr. Friedman if he wants to post just the slides. We also have links to the Choosing Wisely Canada website. And again, if we want to keep this conversation going on the Knowledge Exchange network, that would be great. So I don't see any more questions coming in right now. So I think that maybe I'll just say thank you very much to Dr. Friedman for a really fascinating presentation, and I look forward to hearing sort of the progress of the program at Sick Kids, and hearing maybe presentations about some more of your data once this is up and running, and if there's any changes in your top 5 list, if it happens to evolve over the next few years. It would be really interesting. And I think it's something that maybe we could revisit with other patient safety collaborative calls, and as other organizations sort of start their journey with the Choosing Wisely campaign. So just a big thank you to everybody for coming out today, and to Dr. Friedman for the great presentation.
Thanks, Lisa, and thanks everybody for hanging in there.
Have a great weekend. Bye-bye.